Madam, we are live now.
Okay. Shall I start or you'll introduce?
Madam, you have to introduce yourself and you can start the session.
Shall I start sharing screen?
Yes, yes, madam.
చిన్న చేస్తున్నాం ఓకే ఫేస్ రావట్లేదు. Good afternoon, everybody. Am I audible?
Yes, madam, you are audible.
Good afternoon, everybody. Thank you for joining me in the hot summer for the interesting topic. It is a common topic and very needed topic of the day, that is contraception. Contraception has been being followed right from days when the mankind started, but we just will discuss today what is new in contraception. Greetings from Kim's Hospital, where I am working. Contraception is about choices and access we have, and where the patient has to think what is best for her needs, because depending on the age, her needs, number of children she has, how many days she wants to postpone. There are so many choices now available. So patient has to be given all the information. It's called cafeteria. Everything is served there. It is for her to choose what is available, what is not available. So as population is growing, is a global problem, demand is raising, requirements are changing, then there are always the need for the new drugs. What was new yesterday is something old today. At the time, we were saying pyramids are the highest, tallest buildings in the world. Now we got Burj Dubai, and tomorrow there will be something else for that. Right. Right. So we have to always go for a new type of drugs that is available. What is changing scenario now? We got other end teenage pregnancy, where even 14-15-year children are exposed to pregnancy, and we have to stop that. And other end, you got the late marriages, small family names, an increase in medical disorders, because as the pregnancy is delayed at the age of 35-40, we have patients who are having diabetes, hypertension. So these patients also need some contraception. An increase in medical disorders, availability of new drugs is there, and of course, the pharma is always helping us. The best contraceptives, is always being separate. Now, some people are always, they are in Saudi, patients are in, my wives are here. There's a forced contraception, don't need any, that's the best method of natural birth control. But that's not possible always. So what are the contraceptives available for us? Fertility awareness, that is very important, and the patients should be well educated about it, because they should have a good concept about it. Otherwise, patients may have a wrong understanding about the fertile period, and they may get missed. Next is condoms, both male and female, spermicide gels and foams. You think about what is emergency contraception, because you plan everything, sometimes something goes wrong. And progesterone only pills, hormonal IUDs, newer deadlift techniques, and we got today sponges and vaginal rings. So about this, all the thing available, you should choose which is possible, which is not possible. If you think of the effectiveness, if you don't use any contraception, 15% may not conceive. But vasectomy and tubectomy and intrauterine contraceptive devices, implant contraceptives, there are 99% they are effective in contraception. But coming diaphragm, cervical cap, male condom, still it is only 85 to 76. So depending upon the patient need, we have to counsel them which they have to use. So, sir, all the available types of contraceptives for us. So in this patient is cafeteria, patient has to choose. So if your patient is having, say, long-acting universal contraceptive, 99%, they won't conceive, but the side effects are there. And if you're using short-acting, 91% is there. Other types like other contraceptive methods like diaphragm, male condom, female condom, only 76% is success rate. So the failure rate is about 25%. What is barrier contraception? It has been there right from the ancient times of Egypt, a medicated cloth, even the camels, when they were forced to go for a long journey through the diaphragm, they used to put a small stone in the camel's womb so that it won't conceive. So the concept of contraception has been there right from ancient times. And this barrier contraception, medicated cloth, herbs was used in India. Middle East oils were being used for contraception. Now we got male condoms, female condoms, sponges, diaphragms, and medicated things. Barrier contraception, you got the male condom, which is medicated latex scented, and you got female condom also, which can be used. So that is a closed end is towards the cervix, and open end is thing. If you use reverse way, again it is fail. So patients should be educated as to how to use, when to use a barrier contraception. This is very useful because this doesn't cause any effect on the patient. At the same time, the main advantage is it will prevent the sexual diseases that can be contracted through the sexual act. So sexually, this is also can be prevented by using barrier contraception. And you got for female, you got the today is a sponge that can be introduced just before the act of intercourse, so that it gets swells, effervescent foam-like thing is formed that there is a kills the sperms. So locally acting, again, it is very useful because all these things won't cause any effect on the body. And IUCDs, even we were small, there was called what is called, not even before we became students, the one thing was the Lippis loop. The Lippis loop was kept inside. Even nowadays, we see patients, very old patients with a forgotten Lippis loop. But it's a long tube-like thing. But now you have got the CU 125 or 250, 370A, which are very useful. They are acting for nearly 10 years. So that patient can use, and very cheap, and in medical, in government setup, they are given free of cost, and even otherwise also it just costs only 100 to 150 rupees. This acts for 10 years. So when the patient wants a prolonged contraception, of say she has already completed period, so going for hysterectomy, tubectomy, she can as well use this. One copper T will act for nearly 10 years, and she will not go for permanent contraception. The complications being, you may be having spotting, but because it's invasive thing, patients are scared that something, it will go inside and cause perforation. The patients have to be educated, and by the using this one, it's a quite a easy, cheap, and beneficial thing to the patient. So copper 320A is very important. 380A multi-load acts only for 2 years, and silver gold IUDs are also available. Rings are available. No, nowadays you got a still in the experimental stage. They got a string with all copper balls stringed into the string that is kept into the uterus, and it acts again for 3 to 5 years. That can be used. They are all still in the experimental stage. The best thing we got is 380A. A means the copper is there on the arms of the T also. So this keeps releasing slowly the copper into the uterine cavity, and it prevents pregnancy not only by changing the cervical mucus, but also by increasing the cellular activity in uterine active, so that the implantation doesn't occur. This doesn't prevent any ovulation, or it won't cause. So if it is not properly used, there is still a chance of getting ectopic pregnancy. So multi-load acts only for 2 years, but copper 380A acts for 10 years. So you got copper 250, 380A, 380A has got copper on the arms also, and you have got the silver and gold ones are available. They are not in common use. The other one is Marina. Marina, I think all of you know, it is a medicated one with progesterone impregnated that acts for 5 years, and it is a better one compared to copper T because it's progesterone impregnated. The patient, especially patients who are having heavy menstrual periods, are having small fibroids, are having adenomyosis, pain during periods, you can prefer Marina to copper 380A so that patient bleeding will come down, and even it helps in bringing down the pain and the size of the fibroids and adenomyosis. So contraindication, you should know, recent or repeated pelvic infections are there, suspected pregnancy is there, unless they are sure the patient is in the first or second day of the period, you should not think of copper T, because if you keep a copper T, if she is already pregnant in the late post-ovulatory period, she may have again an abortion. Severe cervicitis, salpingitis, malignant lesions in the genital tract, unexplained vaginal bleeding, unless you evaluate, you should not put an IUCD. And HIV/AIDS, this will not help in preventing HIV/AIDS. The best thing to prevent HIV/AIDS, as I told you, is condoms. And history of ectopic pregnancy, history of toxic shock syndrome. So these are things which will be enhanced by using an IUCD. So whenever you suspect some infection or the inflammation in the cervix, vagina, uterus and the tubes, don't use any IUCDs. Now, once IUCDs are over, the condoms are over, the local sponges are over. So what is the next thing she can use is hormonal contraception. It can have low dose pills. We got second generation, third generation where drospirenone, ethinyl estradiol is common in all these things. You can use drospirenone or cyproheptadine. Also the second and third generation combined oral contraceptive pills. You got progesterone only pill, morning after pill, and you should also think of emergency contraception, as I told you. Patient may plan, but some things, sometimes when you are using condoms, it may burst or it may rupture, it may tear, or it may not be available. So patient is worried, you should think about the hormonal emergency contraception. This emergency hormonal contraception can be oral tablets, or it can also be injections which are monthly or tri-monthly, that is like Depo-Provera. It can be implants like Implanon, and it can be suppositories and Novaring, or as I told you, progesterones can be given in the form of IUCDs. Newer delivery systems, because more effective, fewer side effects, cost effective, easier deliver, and patient compliance is better when you are giving these hormones in the newer methods. So you have got vaginal rings, you have got transdermal patches like spray-ons, gels, or transdermal this thing. Combined vaginal rings are there, or progesterone only rings are there. The advantage is once the ring is kept, it is there for 28 days. Patient not bother about daily taking the tablets, and it is also secret. They may not know that she's taking tablets to anyone. So this vaginal contraceptive rings, first hormonal ring came in 1970. Combined estrogen progesterone ring is there, or only progesterone only ring is there. Nova ring of Hormonal is available from 1990, introduced into the market 2 years back, in Indian market. The vaginal delivery of contraceptive hormones, flexible, soft, transparent ring will be there. Outer 54 millimeters, cross-section diameter is 4 millimeters. Ethinyl estradiol 2.7 milligrams, etonogestrel 11.7 milligrams, uniformly dispersed over EVA core, and release of 15 micrograms ethinyl estradiol and 125 micrograms of etonogestrel. So this acts for 24 to 28 days. So every month you have to use one. Insert and removed for a woman herself. Position of insertion is convenient to her. Time of insertion is in the first 5 days of menstrual cycle. Duration is 3 weeks. After that is discarded. New ring is inserted next cycle. So every month you have one ring to be kept. It is just internal. She should not think of taking the tablets daily. Each ring is there for 1 day cycle. So you in the first 5th day, you insert 3 weeks, the ring is there. You got 1 week ring-free period. It is removed after 3 weeks on the same day. So if Monday it is kept, 3 Mondays on fourth after third Monday, you can remove it. So by just hooking with the index finger, just removed out on, it can be new one can be introduced after 1 week. It completely inhibits ovulation, atrophic changes in the endometrium, thinning of cervical mucus. So the pregnancy is prevented both by ovulation, stopping ovulation, and also by preventing the ascent of the sperm. Acceptability, high acceptability, 88% after 3 months of use. Patient find it very convenient, they can use it. Vaginitis, leukorrhea, headache, and of course, expulsion are more common, so patients should be counseled. So this is vaginal contraception is user control, easily removed and inserted, monthly method, constant hormonal release is there, lowest estradiol dose is there in this because it's getting absorbed from the vagina, directly goes in the first pass is avoided. Gastrointestinal implants, this loss of nausea and vomiting, patient not tolerating the OC pills is not there in this. Avoid hepatic first phase metabolism. Symptoms and side effects are, of course, same like bloating and all may be there. So more wetness, larger colonies will lactobacillus will be there. So patient should be counseled for this. So if slips out within 3 hours, rinse and rinse it. After 3 years, if also it can be more than 1 week, you have to have a backup contraception. And delayed by 8 days, you have to use emergency contraception if it is the ovulation period, or after next cycle, she can use 1 more. So safe, effective, monthly method, well tolerated, user controlled, secrecy is maintained, no protection of STD is the one thing with this, because the only thing that controls or helps you in preventing STD transmission is only condoms. Next comes transdermal contraception. So we are talked about the oral pills, we talked about the condoms, the barrier contraception, we talked about IUCDs, and now comes the transdermal contraception. It works transdermally by slow release of hormones. You got patches, spray, and gels. Transdermal system of combined contraception of both Ortho, Evra, and Evra. Contact surface area is 20 square centimeters, 6 milligrams norelgestromin and 0.7 milligrams estradiol. Continuous systemic dosage of 150 micrograms. These are not very popular in our area because of a temperature. The patches get loosened and the absorption is not proper. So we are not using these patches in our country, especially in our areas. Peak levels are reached within 48 hours of placement. Delivery, weekly delivery and dosage is there. Bypasses, of course, this also bypasses the liver and the gastrointestinal system. But patches in our area, as I told you, because of the heat, they get peeled off, so the effectivity is less. So it may be used on it's a flexible film, provides structure, support, and protection, middle adhesive layer of the environment. Middle layer has got active hormonal component. Third layer releases of inner protective adhesive layer, removed just before application. So the site where it can be applied, commonest is in the hand, but if the patient is conscious and doesn't want to use it on the upper arm as she's having a sleeveless blouse or something like that, it can be used on the back or on the buttocks or even lower abdomen. 3-patch system starting on day 1. Apply 1 patch every week. They should remember that. And each patch should be applied the same day. So Monday, you can use it. And 1 week will be patch free where she gets a period. And this weekly application is easy verification of presence. Contraceptive effects are rapid. Excellent cycle control after 3 months. So all these patches on Marina will have initial first 2 months spotting, and that should be told to the patient and counseled. Otherwise, they say we are having bleeding, they'll discontinue it. Application site reaction may be there. Not very effective in obese women. Side effects are, of course, similar to OC pills. It is outside, so it cannot be concealed. Yeah, of course, I told you it won't help you in HIV and STD protection. Spray-on gels are also same. Gels are also available. It is applied to the skin directly. You can spray it on the skin. So again, that is once it is sprayed for 10-15 minutes, that surface should not be clean. That get absorbed. The local pool is being formed. From there, it slowly gets absorbed. So this is also hormone is collected as a reservoir of the skin, slowly diffuse into the blood. So, but this spray has to be used daily. This is Implanon. Next, it is transdermal. Into the skin, you get a small nick here, and one single rod-like thing comes that is introduced into the subcutaneous thing. You can counsel the patient because it is also a hormonal contraception. Marina is into the uterine cavity. So patient may think it is going into the uterus or something invasive. But here we can concentrate that it is just under the skin. We can feel it and it won't get displaced. Of course, there are rare cases where it gets displaced and becomes an embolus, but that is very uncommon. So it can be used in the patient for especially it works for 3 years. It can be comfortably given to the patient. And removal also is very simple. It's well give a small nick and hook it out. So this Implanon is again a very common, simple, cost-effective drug available, and that can be introduced once your patient doctor is trained. That can be given in the usually it is on the medial side of the arm, upper arm, that is usually on the left hand, and that introduction takes 2 minutes, removal takes only 1 minute. So this patient counseling here also is very important. Like Marina, patient will have spotting for first 1 or 2 months, and very rarely she may have local itching or burning or abscess formation because of infection, and very rarely it needs to be removed. Otherwise, patients are comfortable for 3 years and they take out. And the patients also may have first spot 2-3 months spotting, followed by the oligomenoria or or amenorrhea, like in Marina. So Implanon is contraceptive implant of flexible plastic, thick 4 centimeters long. It is etonogestrel is the drug, 68 milligrams. 1 implant is subdermally, insert between day 1 to 5, effective for 3 years. Fertility returns back within a month or 2 of removal, and dose is small for an application is the, and removal is the only thing a little concern to the patient. But we can always say this is not into the uterine cavity, it is no invasive thing, it is just outside, so it acts better. And it has been once used, Saheli, now it has been again coming back. This Encroman is the one which is again 60 milligrams. It can be given patient after once, twice in a week, or once it is used for 2-3 months, 2-3 weeks, you can just use it weekly once. This also is very effective, very cost effective and cheap one, but still you have to, patient has to be counseled and patient has to be followed up, because these patients, when they are used for a longer period, they may have developed liver cirrhosis, and there may be patients who are having ovarian cysts developed by that. So this is a local thing and it is not much used, but a very useful drug available. And comes lastly the permanent contraception, that is surgical. You can do it like with laparoscopy, bands, laser or diathermy, or bipolar coagulation, or monopolar coagulation, that is tubectomy. You try to cut the tube or tie the tube so that the released egg doesn't come into the uterine cavity, the permanent contraception. Or you can go, that can be done even histoscopic sterilization. You put, that is called assure sterilization method. Histoscopy is introduced, you see the ostia, and that pre-coil thing is pushed into the ostia so that it goes into the medial most part of the tube, gets uncoiled, and this is again a permanent contraception. Patient will not conceive again. No cut is there, and it can be done as an OP procedure and patient will, but still it is costly, not at widely used in our setup. This is the histoscopic sterilization. This is the introducer. Just put a scope, look into this thing, you can see the ostia, just put the disengage it into at the ostia level so the tube gets blocked. Again, this takes at least 1 or 2-3 weeks for the epithelialization to occur and tubal block occurs. Till then, patient has to use some other type of contraception, otherwise it will go into an ectopic pregnancy. Now, what about me? See, we're all talking about all only female contraception, female methods. How about male methods? So this male also you got, of course, condoms. Apart from condoms, you got new male contraceptive techniques like vas deferens and urethra there. Sperms are blocked at this point. The cross-sectional tube, you see, 2 silicone plugs are inserted into each vas deferens. A stitch holds the plug in place. But one thing is, whatever you do, vasectomy or recanalization of the vas or put these into the patient will develop anti-sperm antibodies and they will go into permanent contraception, contraception. So patients are not willing to get it done, because tubectomy can be recanalized, then it is successful. Vasectomy, if you do vasectomy is of not much use. So, but they have come out with new drugs like Adjudin, Resag, and vas occlusion experimental still in the vas, and heat-based experiments involve heating the testicles to a high temperature for a short period of time. But these are all still in the experimental stage. This Adjudin is a chemical currently in phase 2 human trials, and Resag is reversible inhibition of sperm under guidance. Experimental injection of spermicide substance into the vas difference that coats its walls. The method can potentially be reversed by washing out the vas difference with the second injection, but still, it is still under consideration. As I told you, anything you disturb the vas or the testicle, a patient will develop anti-sperm antibodies, and even if the sperms are developed in future, they may be killed. So you have to be very careful, evaluate better, and if unless they are ready for permanent contraception, these are not to be used. So in female, you got pranim, buffer gel, and duet, and these diaphragms. These are all polyherbal vaginal tablets, microbial spermicidal against HIV also. And they got a spermicidal gel that is microbicidal active against HIV. So apart from this, now the greatest contraception is you got the contraceptive hormones impregnated into jewels. The patients are asked to give small stud-like things so that it looks as if it is a stud. It is being absorbed from the skin, and the patient will have each stud is worn every month. So she wears a stud like a jewel, but it will be releasing the hormone. So patient will have contraception at the same time. She will have a beautiful thing. Like this, you are having small balls which are reduced into the uterine cavity. That also will have contraception which is being released into the uterine cavity, and so that causes contraception. So these are all the new techniques that are being used now, because patient wants to use a contraception method. At the same, she doesn't want it to be invasive, and then same cheap, cost effective, and then she wants to not, compliance should be there for us. And the same time, patient doesn't want to reveal that she is using contraception. So taking a tablet daily, she forgets all that can be overcome by injectable and implants. So you got a vaginal ring, spray progesterone, quinacrine can be there. And with all this, what is the protection you get? If 85 in 100 women will get pregnant if they don't use any contraception, and 99% is the efficacy rate if you use any of this reversible long-acting, as LARC. LARC is long-acting reversible contraception, like you got Implanon, you got hormonal intranet device, copper T, and these things, male sterilization, female sterilization, 99% is the success rate. Why is that 1% is left behind? There are still failures. When you do tubectomy, sometimes again, they get recanalized on its own, or one of the tube or end gets opened up, it can ectopic, or she can have a failure of sterilization she may conceive. So that 1% is left behind. And short-acting reversible contraceptions, when you are using the vaginal rings, again 91%. But with these uses like diaphragm, male condom, female condom, withdrawal method, fertility awareness method, you got only 76% success rate. So best is to use long-acting reversible contraception. Of course, non-reversible is this thing, male sterilization, female sterilization. Next comes the short-acting reversible contraception. So as I told you, contraceptive injections, contraceptive vaginal rings, combined oral contraceptives will have only 95% effect. So with this, we have all the types of contraceptives we have available with us. So just see for which case you can choose what. For example, let's say young, newly married software professional, obese, hirsute, acne she's having congestive dysmenorrhea, irregular periods, wants to postpone a family for, say, 1 year or 2 years. And what should we choose among all these things, criteria? Once you want something drug to correct her problems like obesity or acne and bring down her pain. It should be an effective contraception, well tolerated, lipid friendly because she's already obese, soft on thrombosis, and minimize her acne. So for this, you got a oral contraceptives where you can use a drug like Diane 35, whereas these patients definitely they'll bring down the acne. In case 2, She is 25 years, para 2 L2, LCB 2 years, wants spacing. So she's already had 2 children, she wants spacing. So she is 25 years. So you want a better is to use a long-term acting one which acts for long time. It's less costly. And so what to offer? You got IUCDs or OC pills. Best is IUC because 2 children, remember OC pills taking daily is difficult, and low socioeconomic status, you can use always IUCD, which will act for 10 years, and it's available in free of cost in all the government setups. Even in the private setup, it's quite cheap. So best would be IUCD for her. It acts for 10 years. It's cheap, available, and no daily intake, no extra intelligence required, and only occasional follow-up needed to say once in 6 months or 1 year. Only thing you have to say that if she is an abnormal bleeding, she misses her period, she should come and report to us. So cervical lesions, irregular periods, PID, adnexma, endometriosis, fear of perforation are there. So these things you have to examine the patient first and come and explain her and do it. Next thing you have got is Malayan or Maladi. This Malayan advantage is got 28 tablets. 28 tablets, you not remember, take 21 tablets, stop, wait for the period to come, again restart on the 3rd day. Instead of 28 tablets, you'll have 21 tablets, hormonal tablets. Another 7 tablets will be placebos, or it will be having iron capsules. So during this gap period, she'll get a period. So she'll not wait for the 5th day or 3rd day. So it doesn't need much IQ. So you start the tablet on the 3rd day of the first cycle. You continue pack after the pack, so that she'll be taking continuously one pack after that. These are also will free of cost in the government setup, and they can take it for thing. But the only thing is she has to be very careful to taking it daily at the same time. If she misses the tablet, you have to tell her that next day morning she should take it. But if she uses more than 2 tablets, she has to use some other method. Now she's 30 years, 55 kgs, para 1 L1 with dysmenorrhea. Irregular, unpredictable periods, seeks advice. So if one is you have to regularize the periods, she should alleviate a pain, she needs a contraception, no risk factors. So for this, you can simply use norethistron. So this will have with ethylene combination. This will bring down the pain because she is young. You can use these OC pills regularly so that she can use, because she is educated, she can remember these tablets and take them. They are lipid friendly and helpful. Or she got a new generation OC pills like low dose pills, and I got 21 tablets. They are commercially available, minimal side effects, very effective. Needs, of course, thinking regular use. Now, if this patient is a husband abroad, visiting for only for 2 months, going to tour with the family and needs advice. So this patient can have a Novary, or she can also have a single dose of Depo-Provera, which acts for 3 months. It will cover up for all her 2 months period with her husband stay. Need not go for copper T, or need not go for a rosin OT pills, where because she is going a tour, daily remember and take the tablet. So the short acting contraceptive pill is very effective. So she can use an Novary, or she can use a Depo-Provera injection. She is delivered 2 months back. She is lactating, came for contraceptive device. The safe drug for mother and infant has to be used. So you got only progesterone only pills that are available, that is Cerazette. Newer spray gels are also available. Local vaginal rings are also available. There are only progesterone, which is safe for the mother and also the baby. So these things can be used. Another 35-year-old, para 2 L2, she is obese, hypertensive, gestational diabetes, want contraception. Here, better is drospirenone with ethinyl estradiol. Drospirenone was once thought to be causing the clots, that is the DVT, but it has been now used, very frequently. It has been ruled out. So you can use this, what is called Yasmin or Rasana. Different brands are available with drospirenone. You can use them. Now we are having simple drospirenone also with estradiol. So the estrogen content is reduced. You can use this for also contraception regularly. Again, this is Nagamani Parrot 3, 2 previous LSCS, heavy periods, and cannot take tablet regularly, doesn't want an IUCD at all. So even Marina is ruled out. So the only thing you got is Depo-Provera you can use Norplan, progesterone only drug, once in 3 months injection also that is there, and 100% contraceptive and is cross effective. So these patients can also go for Marina, but she doesn't want an IUCD. The only choice you got a Norplan or a Depo-Provera. But the thing is, she can have a breakthrough bleeding. This also has to be advised. And sometimes single injection Depo-Provera will take the patient into amenorrhea of say 6 months to 1 year. So this also has to be counseled. Sometimes it is difficult for us all to bring her back to regular period, especially younger patients. So this is Depo-Provera not planned. We usually choose for patients who are 30 and above. Another patient, I can tell you, she's a bulky uterus with seeding fibroids. Better is use Marina, is actually only both for contraception and bringing down the bleeding, and also for bringing the size of the fibroids also down. And these were having a rhythm method they were using, but they missed it. They are panicky. So you have got what is called an emergency contraception. It has been taken within 72 hours of the act, and no need for 10 days between use. It can cause DUB. So I have got one patient couple coming to me. They use I pill 3 times in the same cycle, but still miss the period. So you should know if it is used during the fertile period only, it has used. Simply after every act you take I pill, she will go into irregular periods and develop abdominal bleeding. And HIV couple both infected. Do they need any contraception even they are tuberculosis? No, they need barrier contraception because new strains keep coming up. No effect on general health. So protects future infections because new brands do see, because strains are coming, they are again repeatedly infected. So even if they don't want contraception also, if both couple are infected, better advise them barrier contraception. So I think I've just told you the types of contraception available to us and what to choose in which patient. Thank you.
Hello.
Hello.
Yeah, madam. There are some questions also now.
Sure.
Posting one by one question in the chat.
Yes, yes. When you place a implant is placed, thing is long term, only if there are few cases where they see that the ovarian cysts have developed in some patients, but it's not a common thing. The only thing is they should tell us they missed a period, because these patients can go into oligomenorrhea or amenorrhea. So there's an expected thing, but they should come and check up once in 6 months so everything is okay or not. And their lipid profile should be done before you insert thing. LFT has to be done before you start this. If she has any untoward effect, she must come and report to us. The intrauterine devices, as I told you, it's very, very good. Properly inserted. IUCD, copper IUCDs are cheap and best, and they are cost less and they act for 10 years. Now, actually, in government setup, we are encouraging what is called PP-IUCD. That is, patients are not coming forward for IUCD and having unwanted pregnancies. So after delivery, at delivery, or within 48 hours of delivery, the copper is inserted into the uterine gut. That's called PPI, postpartum IUCD. These patients should be informed that as the size of the uterus comes down, the threads may come out. They may come to us for shortening threads, because this will prevent the pregnancy for more than 10 years. But after 1 or 2 years, it can easily be removed after the copper after the patient wants next pregnancy. But very rarely, if not properly introduced, it may get perforated. But even you keep it in the PPICD period, because uterus is very thick, nothing happens to 99.90%. But when it is introduced in the postnatal period, especially within the 4 to 8 weeks, the uterus is very small and supple. If you're not careful, there's chance of perforation. But even carefully kept, nothing will happen. And these are effective. And this medicated, this is copper IUCDs. You got progesterone impregnated IUCDs like Marina, and there are other brands are also available. These are very effective and were given in the postpartum period for the contraception Even it will help in bringing down the AUB also, by reducing the bleeding. And at the same time, it acts for 5 years, and it is very effective because it is also takes the shape of the uterus and uterine cavity, and patient is tolerates it very, very nicely. And it also needs checkup only once in 6 months or 1 year. Otherwise, they are very good. There are advantages. This contraceptive regimes, as I told you, you got low dose contraceptive pills, only progesterone pills. You got estrogen is okay, but progesterone, different varieties are there. So according to the patient is say around 35 and she's obese, she is having hypertension, diabetes, and lipid profile is altered. For those patients, drospirenone is better. Young patient, you can use isoniazid or norethistone like Novilon. And for patients who are having acne and young PCOS, you can use these things, drugs like Dian-35, where drug acts not only on the contraception, but also helps in the lipid, bring down the lipid profile and also the acne. So it is more friendly to the patient. So you should choose as per the drug available so that you can use. The patient will have the other benefits. Apart from contraception, other benefits are also there. This 91-day combined oral contraceptive actually is not available with us. It is good. That is for once in 3 months you take it. And you got injections are there available. That is very good. But 91-day oral contraceptives, I don't think it is available in our setup. And that also patient continuously takes it. That helps, especially in young girls who are having severe, heavy menstrual bleeding during periods. And not only that, they're going to severe anemia. So these patients are very helpful by taking the 91-day combined oral contraceptive, because it brings down the bleeding, and because it is delayed by 3 months, anemia is corrected, and patient general health also will help. And the same thing around young patients who are having, along with this thing, contraception, they are having menorrhagia. This once in 91 days they can take. But the thing is, they should remember and take it, because in between this stop, they'll have again bleeding and the intermenstrual bleeding, which is very annoying, and sometimes even the family is also disturbed. Instead, you can as well use an injection which acts for 3 months.
Hello.
Hello.
Yes, madam. We are done with all the questions now.
Okay,
okay. Thank you very much, madam, for the valuable time.
Bye. Thank you.
Bye, madam.
And thank all my participants who joined me. And good afternoon.
Yes, sure, madam.